My name is Natalia LeBeau. Thank you again for coming to my presentation on my journey through the DAT, which is my Doctorate of Athletic Training. Right now I'm going to be discussing all of the data collection that I've done with the athletes here. I'm going to refer them to as patients as the presentation goes on. So if you look at the first page, the first thing that, again, I'm going to be going over is the data collection that I did here at Jarvis Christian College from the beginning at the end of August until now. So the first thing is changes of pain using different paradigms, different techniques that I've used on the athletes here. My philosophy through athletic training is using a hands-on approach. I like using more of my hands-on to work with the athletes instead of just doing the normal rehab tools that we have here at Jarvis Christian College, instead of the ultrasound machine that we have, also the electrical stem machine that we have. So this one is the first thing, outcomes that we've done is numeric pain rating scale. So I have the patient come in. Normally I have a form that I fill out at the end of the day, but I ask the patient, hey, from 0 to 10, how bad is your pain? 0 being no pain at all, and 10, the worst pain imaginable. And then that's one of my outcomes that I do on the patient every time they come in. The first technique is called the Mulligan concept. So I've done it a couple of the volleyball players here, also a couple of the track athletes here, and softball and baseball players here at Jarvis. The Mulligan concept is, there's a lot of wide variety of this concept is using my hands, and that's one of the main reasons why you see a lot of data collection on this technique as well. So what it is mobilization with movement. So for example, for an ankle, if someone has a true ankle sprain, I'm going to use my hands to essentially move the joint into the painful movement, but actually put my hands onto the lateral side of the ankle where it's your malleolus, which is on the side. And I actually push onto the slight push, and they go into that direction of free. It should be pain-free as I do that with my hands. Also, I've done it with the knee, which I'm going to show you that I've done a publication, hopefully turning into a publication, where they have pain in meniscus. So they've had a history with meniscus pain. And what I do is I essentially put my hands onto the most painful motion of the knee. And I have them go into the motion that they have trouble with. So say they have trouble with flexion, going into that motion. I'm going to put them in that motion, but provide that push onto the side of the knee where they have that pain, and I essentially push all the pressure that I do. And essentially with that, they're going to have 0 pain with that. So if you look at the data here, overall I've had probably 10 to 15 patients that I've worked with, and an average of 2 to 3 treatment sessions. So after I've done the treatment 3 times, this patient can actually go on and play without any troubles or any issues, compared to the normal rehab or stem. Stem, I've had people on it for, can't even remember, like 2 to 3 weeks, and they still have pain. So this is just another technique to get the patient back into play, and the coaches are all happy having their athletes back into play. So the next one that I'm going to go over is the total motion release therapy, which is called TMR. So the theory behind that is it's a regional interdependence model. So which means that if someone has pain on their shoulder, that pain could be coming from their hip essentially. And so what that is if the pain, so say that this person has pain going forward flexion like this. This is painful. So what the theory behind it is, if you do it on the opposite side, essentially gravity, and the theory behind it is gravity is going to pull it back into the center, and they will have no more pain in their shoulder. So by doing 3 sets of 20, 2 sets of 20, you can set how many sets and repetitions you want to do for the patients. And if you look at here, I had from the end of August until now, I had 2 patients that were both, one was a baseball player and the other one was a basketball player. Baseball player had, for example, had a hip flexion strain. So he had pain with going this motion. So what I did is I had 3 sets of 10 going this way, and essentially after three treatment sessions, there was no more pain, and he was able to go back to baseball without any issues. The next one on your right was a basketball player that had a shoulder strain, a rotator cuff strain. And so the same thing, he had pain going this way and actually going backwards. So what I did is I said, okay, let's do 2 sets of 10, going this motion, and then again, going backwards. And we did that for about 3 to 4 treatments, and he was able to go back to basketball practice without any issues. And essentially, yes, so TMR, what this does do is they rate between 0 to 100. 0 meaning that there's no dysfunction, they have no issues, nothing with pain, stiffness, or tightness. 100 means complete dysfunction, meaning that they cannot perform that technique that I'm giving them. And then they have to complete, in the TMR model, they have to be able to have a 0 to a 5 of pain at the end. But I tend to, with my patients, I tend to have them come close to 1 or a 0. Because I feel like if they still have pain, I still want them to get to that 0 pain. So if you look at the next page, another paradigm, another technique that I incorporated here at Jarvis Christian College is neurodynamics. And what neurodynamics is that it's the relationship between the muscle and the nerves. And what the technique is trying to essentially do is bring those two relationships back together. So if a patient has issues with, so I use it a lot with my elbow patients for baseball. So they had a lot of times when they do an overdoing of throwing motion over and over again, and they don't know why they have pain. There's no other causes of it, no strains, no muscle strains, or any of that. Essentially, it's coming from the nerves. If they're having a lot of numbness and tingling and sharp pains after they're throwing or after a throwing motion, that to me, it goes into this technique because they're essentially loosening up the muscle and also working with the nerve bed, making it essentially stretch. You're not really stretching the nerves, but you're actually making it to more of a flowing motion with this technique. And then again, I did 2 patients where they had their pain almost at a 6 on one baseball player, and I got it down to, after 2 treatment sessions, he was down to a 1 or a 0 in pain. The second one, which I will be discussing later in the PowerPoint, he had a pain of over a 6 or a 7, and he was able to come down after 6 treatment sessions. He was able to come down to 0 in pain. The next slide is going to be on, again, my patient-reported outcome measures. So measures that I talked to earlier before about the NPRS, which is the numeric pain rating scale, 0 to 10. These are just other few ones that I've been focusing on with these patients. Okay. So the disability and physically active scale, which is short DPAS scale, this has 4 components in it within the survey. I have them completed, which is 4 questions on impairment. What is, based on your pain or based on your injury, what is impairing you from doing different types of physical activity, running, walking, for example. Functional limitations, again, what is causing, based on your pain, what is causing you from not doing the weight room? What is causing you not to do all of that? So you rate that. Next is the disability and then quality of life. This also not only focuses on your injury in terms of, okay, this is painful, I can't perform this certain technique. But the quality of life is based on my pain and my stress, based on my pain and my not having good relationships with my friends or my family members. Am I not having it, for another example too, it says coaches, if I'm not having a good relationship with my teammates and things like that. So it looks at the overall patient instead of just one specific for the pain. And you can see here, based on the DPAS, I've had over 10 to 15 athletes completed. Like I said, I do not only the 0 to 10 of pain, but I also give them this DPAS form that I have them complete before the treatment, and then I do it once a week depending how long I have the patient with me. So most of these patients, we either have it once before the treatment and then after, depending on how they were doing. But normally you would do it once a week just to see their overall tracking, because you don't do it every single day. So the next one that I'm going to be discussing is the patient-specific functional scale. The patient functional scale is, in short, PSFS, which is it's a form that the athlete comes in again. I do it before. They rate their three to five top activities that is going to be that causes them pain. So for their shoulder, what causes? Give me 3 specific activities that cause you pain. So they would rate it, and they would have to say, okay, running for 30 minutes, or lifting weights, bicep curls, anything that they think or they perceive as it being pain for their shoulder, hips, knees, or ankles, or any type. So from there, from this outcome graph, you can see that I had, in general, I have them all just complete top 3. Give me top 3 activities that cause you pain. And I know it shows that, so it's from a 0 to 10 scale. So this is actually opposite. 10 is that they are able to perform the activity with no problems, okay? And then 0 is unable to perform. That's why it's a little bit opposite compared to the other treatment sessions. And how you get the numbers by this is you divide, so say that a person had all of their 3 activities was, 5, 5, and 5, 3 activities that they couldn't perform. That's 15, and then they divide it by this survey, you divide it by 3, and that's when you get the overall number on the overall how they're doing before, and then I do it after. And again, this activity, this survey can actually be done before and after treatment. Okay. So now I'm going to go over the 2 manuscripts for possible publication, which I'm very excited about. One of them right now that I wanted to let you guys know that my professors are actually going to be, we are hoping to publish for next week to turn it in to see if it gets published. So the first manuscript, it is on the Mulligan concept that I spoke on earlier. It's the squeeze technique. So we had a little bit of short little story about it. It was a basketball player, and he was in pain for about 7 or 8 months before he came to see me. He had a meniscal lesion that we weren't sure if it was positive or not. He never got an MRI. But what I did is I looked at it, let's see what's going on. So I had him, I did a full eval, and by my clinical examination, my evaluation, he had a positive meniscal lesion. So instead of just him going through rehab, I wanted to confirm that with an MRI. So I can use it not only for myself, but also for my research. I felt like this was never been done before yet in research. If you look in the publications, it's always having a positive meniscal lesion with just an evaluation. So I wanted to confirm my evaluation with an MRI, and I did that with this patient. And if you look at the data collection on this patient, I used, again, patient-reported outcomes, which was the NPRS, which I spoke on earlier, pain, and also the PSFS that I spoke on earlier, DPAS, and the KOOS. The KOOS is a knee injury and osteoarthritis outcome score. If you guys want a copy of that, I can more than be glad to explain that to you. And then based on these tables, so table 1 shows what I did 12 treatment sessions. But for the point of my manuscript, I had to cut it down to show the importance of it and to show the powerful of this. So I cut it down to initial, when he first came in, at 1 week, when he came in again, and then at discharge. So discharge meaning that he was done with the treatment and there was no more pain. He was able to do full basketball activities, and he was able to have it with no pain, any further pain. And again, those are just what it stands for underneath the tables, the NPRS, and all of that. Then table 2, we go into the post-discharge follow-up, meaning, like I spoke earlier on, that no other publication has been done before on a positive MRI imaging, and also long-term follow-up. There's a lot of studies out there, again, that's only done a clinical evaluation on the meniscal injury and no follow-up long-term, which means 6 months. And I was able to do that at 1 week, at 2 months, 3 months, and 6 months post-injury. Look at the last manuscript, that this is the one that my professor is, we are hoping to send it to publication next week. This is a case review, again, that I spoke earlier on, neurodynamics, treating elbow pain. So again, this was a baseball pitcher. He had issues with his medial elbow pain, which is the inside of your elbow. He did a normal pitching throw 7 months ago. He didn't understand why he was having so much pain and numbness and tingling after a single pitching practice. And so what we did is I got him through based on the technique and based on the theory behind it. I had him perform 2 neurodynamic sliders. Again, it's just going into the opposite motion. So for example, if this is painful going this way, I'm just going to come out more. Kind of more of a stretching, light, back and forth motion. And again, if you want pictures or any of that, let me know. And we did that for about 6 treatment sessions. Within 6 treatment sessions, he was able to have full motion and being able to pitch without any issues. And again, this table just shows you what I did day 1 all the way to day 6 on treatment. And then again, I did a follow-up, which hasn't been done on a baseball pitcher and also hasn't been done on a medial elbow pain for that. And I did a follow-up for 1 week, 1 month, and 3-month follow-up. Okay. And then these are my references. And again, if you want any copies of any of the surveys, let me know. I will be glad to send you those pictures and if you want more information. So again, thank you. And then if you guys have any questions, please feel free to ask them right now.
Question: how many treatments do you schedule for each student athlete to go through? What is your max that you want them to go through to allow to see if the treatment works?
If the treatment works. So normally with any paradigm, it just depends on the athlete at the end of the day. So when I have them come in, I'm hoping they are compliant with me, and I tell them to come in, give me a week or 2 just to see what's going on. So I have at least a limit of myself. If I can't figure it out, I go straight to you, and then I also go to the doctor and say, look, I've tried everything for the past 2 to 3 weeks, for example. So I try to give myself at least 2 to 3 weeks to kind of figure it out what's going on. And then if not, I use other resources. I use my relationships with physicians, because as an athletic trainer, you are taught to have relationships with everybody else around you. So, yeah.
Question.
Yes.
Have you done any research in regards to these concepts in comparison to such as the STEM or even on ice and heat type method? What was the outcome or the comparison between these methods and the traditional methods that most athletic trainers use, such as ice and STEM and those type of things?
Yes, no, of course. So with the 2 manuscripts that I just hopefully getting published, I actually looked at comparing those interventions to ultrasound and to cortisone injections. And they came up with, there was one article, don't quote me on exactly what happened because I do have the copies of it. They did it was tendonitis elbow. And what they did is, I think they did it on multiple patients. I know that. And what they did is they did cortisone injections on one group. They did therapeutic exercises, which was progressive exercises on rehab, so strengthening. They did a lot of balancing, a lot of throwing mechanisms and things like that. And also they did it on, like I said, ultrasound and then STEM. What they found out that the therapeutic exercises actually lasted longer. It was like a 12-week program. And yes, they had resolutions, but it was a lot longer term, if that makes sense. With the ultrasound, again, don't quote me on it, but I know it was longer. I know it was longer than a month just doing the ultrasound. And again, the cortisone injections, they did it, but however, they had long-term symptoms, meaning that they had a lot of pain later. Or when they did an MRI, it showed that it just essentially just kind of deteriorated the joint and the tissues around it. But again, that's only one study, and I've done other ones where they do work. It's just a long-term follow-up, therapeutic exercise and an ultrasound and STEM.
From your research, the suggestions that you have, would they be to an athletic trainer or to physicians as such? What would be those recommendations and to whom?
The recommendations on the.
From your study, what would be
Oh,
your
yes.
recommendations? Yes, ma'am.
It would be more recommendations to athletic trainers to see that these new, they're not essentially new paradigms, but they are new techniques for a lot of athletic trainers that have never dealt with these paradigms. I can have these patients come back in less than 2 weeks compared to rehab tools or ultrasound or stem. To have this possibility to work with their hands-on approach to patient care essentially. And that's what I want to do with my practice, is also even go into my goal of teaching and showing that the future athletic trainers or whoever I start teaching knows what the difference between just putting ice on a patient, but actually interacting with the patient and knowing where they are emotionally too as well. So yes, it is geared towards that, but hopefully I would like for physicians to read these articles and again to other professors that want to be in this field.
Sounds like go ahead.
No, does that answer your question?
Yes, it does. Sounds like a video for training that you may have as a sidebar.
Yes.
This is great.
Yes.
Yes.
Thank you, everyone.
Thank you.